Hello, my name is Angelina Jayakumar and I'm a consultant physician in infectious diseases, HIV and general internal medicine. I work at Barts Health NHS Trust in North East London, and we have a large catchment area of about 4 million people. Our patient population is very diverse and we have a high immigrant population, and a subsection of the patients in our service are from vulnerable and marginalised communities. Within the UK, long-acting injectable therapy has been approved for use since 2022 by BEVA, otherwise known as the British HIV Association. The BEVA guidelines recommend long-acting injectable therapy for patients who meet the following criteria. So those who are motivated to use the medication, those who are virally suppressed for at least 6 months or more, who have no known resistance to NNRTIs or INSTI antiretroviral therapy, and who have no previous virological failure with NNRTI or INSTI containing regimens. They also recommend that patients who use the medication engage in shared decision-making in the process, are not at risk of hepatitis B reactivation, and do not have a body mass index of over 30. We can and do use long-acting injectables in patients who fall outside of this criteria, either as part of a clinical trial or we offer them compassionate access on a named patient basis. Within our trust, as I mentioned, we have a diverse cohort of patients, in particular of sub-Saharan African, South Asian and Southeast Asian origin. Some of the common issues that they encounter are stigma around the HIV diagnosis, fear of disclosure, and socioeconomic precarity. We have approximately 200 patients on long-acting injectable therapy, and we try to offer it equitably. So, for instance, 30% of our patients on long-acting injectable therapy are women, which represents our general patient population. Our specialist HIV nurses deliver the medication, and they do this mostly in our outpatient HIV clinic. We try to use long-acting injectables to support those with adherence challenges, issues around disclosure, and socioeconomic precarity. Most people confirm an improved quality of life with this medication. This is because it gives them freedom from the daily reminder of HIV that they had from taking pills, and also freedom from the worry that other people would know that they had a chronic illness. It also gives them relief from pill fatigue, adherence anxiety, and the freedom to travel. In terms of recommendations for other centres, I think I'd like to highlight that studies have shown that even those who report minimal psychosocial challenges at baseline still experience meaningfully improved treatment satisfaction with long-acting injectable therapy. This was shown in the SOLAR study, which was a randomised, open-label, multi-centre trial that compared participants who continued on Biktarvy with those who switched to long-acting injectable therapy. The study showed that long-acting injectable therapy was virologically non-inferior to Biktarvy, and participants experienced significantly improved treatment satisfaction and good levels of acceptance of injections over time. I think the take-home message from this is that it's valuable to discuss long-acting injectable therapy with all patients who meet criteria, not just those who experience stigma.